I'm Jim Blakeman, Senior Vice President for Emergency Group's Office, your billing company, here to welcome you to our series of brief talks about documentation essentials. We will focus on what needs to be in the medical record to adequately support proper coding and appropriate reimbursement. The process of reimbursement is really about communicating the value of emergency care. When your encounter with a patient happens, the value is defined at that time by your quality of care. The coding and billing process must then make sure that what happened between you and the patient gets communicated to the third-party payer in the language they understand so that they can reimburse it appropriately. It really is all about the patient. We don't want you to compromise your relationship with the patient by putting things in the record so you can just bump up the level, or by making the record include anything that isn't true or didn't happen. When you've done the right thing for the patient and the record reflects that, the third-party payers must be held to account for appropriate reimbursement for the value of your work. There are a couple of rules that I think put physician reimbursement in its proper context. First, no one pays you what you're worth. They pay you what you negotiate. It's an essential business principle. Fair payment is a negotiation process. Your negotiation with the payer involves not just the terms of a contract, but also how you prepare your record. You're negotiating for appropriate reimbursement by documenting properly in the record so that the insurance company understands the value of your work. Second, you don't get paid for what you do, you get paid for what you document. And we don't believe that if it wasn't documented, it wasn't done. I'm glad that emergency physicians do much more for their patients than ever gets into the medical record. But when it comes to payment, if it's not in the record, payers can say, we don't know whether you did it, so we're not going to pay for it. The principal thing that insurers are willing to pay for in this era of healthcare reform is your thought process. Payers are valuing now more than ever your decision-making process, not just the final conclusions, but how you came to those conclusions. So we suggest that you think in ink. Remember to put your thought process into the record so that the insurance companies can value it and understand how you got to your decision. This slide shows the relative value differences between the visit levels. As you can see, critical care, that is CPT 99291 on the far right, has 6.27 RVUs and it pays 29% more than a level 5. A level 5 at 4.85 RVUs pays 47% more than a level 4, but the biggest difference in visit levels is between a 4 and a 3, a 91% variance there. So you'll want to explore ways to make sure that your middle acuity patients that warrant level 4s don't have to get reported at the lower level. The losses, as you see here, can be significant. Here we see the Medicare payments by visit level. During the medical decision-making talk, we'll discuss how to prevent losing some level 4s by having to code them as level 3s. The cost of healthcare continues to go up, and Medicare is concerned that costs to the program have gone up much faster than expected in recent years. One of the small, frankly very small, contributors to that is emergency medicine. Over the last 10 years, our visit volume, as shown in this graph, has gone up about 19%, or only about 2% a year. But payments for emergency physician specialists and emergency E&M codes have gone up by 75%. Why is that? Well, intensity of service is what drives payments as well as volume. So Medicare knows that not a lot more Medicare patients are being treated in the fee-for-service program. Most go to managed care plans. But we are reporting many more intense services year over year, and they are being paid at a higher level. That's what this graph shows. Volume isn't driving cost for fee-for-service increases in emergency care. Coded acuity is. Just over the last 6 years, you can see the significant rise in the reporting of these services. The blue columns are level 5s, the red columns are level 4s, the yellow is a critical care line. In part, that's because more patients are coming in sick these days. Lots of studies have been done recently that show an increased clinical acuity in ED patients. But part of it, frankly, is because coding is better, and physicians are documenting better when using electronic records. So we have some challenges to the accuracy of coding that we'll talk about next, so we have to be careful there. The Office of the Inspector General is the enforcement arm of Congress. They're to root out all waste, fraud, and abuse in the Medicare program. They put out a report in May of 2013 where they identified 99285 as the fastest growing evaluation and management service in the entire House of Medicine. We are growing faster in use of 99285 than any other specialty, 129% growth over the last 10 years. So the OIG has gone in depth to look at Level 5 services because, as this slide shows, it is the 7th most expensive line item in the entire Medicare Part B budget. Yes, emergency medicine total costs are only about 3% of total Part B Medicare expenditures, but the 7th most expensive item is the Level 5 emergency visit. When Medicare goes to look for waste, fraud, and abuse, they're going to look at the most commonly reported services to find the errors. So there's a lot of audit activity on Level 5s. We see this constantly, not just from Medicare, but also from the Medicaid programs and from commercial insurers. The Department of Justice back in September 2013 looked at the problem of increased high-level visit reporting and concluded this must be related to cloning in electronic records, and it's resulting in upcoding. So, okay, we know that there is an inappropriate use of electronic records. There is cloning going on, and where things are reported because they are in the template, but they didn't actually happen. So the Department of Justice felt it necessary to put out information about their intent to investigate, and they say here that false documentation of care is not just bad care, it's illegal. Those are pretty strong words. They are aggressively looking for providers who are committing fraud. The administration is looking to change the way it pays for care, and Medicare is going to do that going forward with quality indicators and quality measures. They exist on the hospital side now, so we're about to see them take place on the physician side as well. As a result, in the not-too-distant future, payment mechanisms will look somewhat different than they do now for Medicare. Suffice it to say, there's a lot of audit activity, and EGO, frankly, is very proud of its record of winning about 98% of the thousands of audits that have occurred over the last 4 or 5 years. We believe that we can adequately defend the chart in the way that it's coded, and the best defense, obviously, is being able to point out to the reviewer the really good care that the physician provided. Regarding cloning, some studies say that physicians using macros, particularly emergency physicians in one study, are not doing the work. They're simply cutting and pasting from old records and making every record look exactly the same. Now, can you use macros? Yes, you can. Here's a Medicare transmittal that says specifically that physicians may use a macro as the required personal documentation if you personally add to it, that is, you provide customized information to support medical necessity so that the electronic record sufficiently describes the specific services to the specific patient on the specific date. But of course, misuse of the macro is what has gotten some public attention, so we have to be careful about how we're using our electronic records. Obvious medical implausibilities like descended testes on 2-year-old females or pregnancy tests given to adult males, they just make no sense. Contradictions within the chart are also a problem. This HPI describing this patient with a left facial droop is later contradicted in the templated neuroexam, no facial asymmetry at rest or with movement. Implausibilities and contradictions tend to prompt the adversarial payer to ask, "And doctor, what else were you lying about?" So be careful about how you use paste functions and how you use your templates. Make sure that the templates properly describe the patient's problem and your care. Clearly, every patient does not look like every other when they present their case, so we don't want our record to look like that either.